So now I'm going to walk you through a couple of antagonists, and we're going to discuss how they appear on physiological tracings. And again, we're going to look at diastolic pressure, pulse pressure, mean arterial pressure, and heart rate, and going to together predict the responses and also discuss how that looks on the classical responses to each of these antagonists. So we're going to start with atropine. Atropine is a muscarinic antagonist, so it blocks M2 and M3 receptors. So let's first look at diastolic pressure, and this is determined by systemic vascular resistance. So atropine definitively blocks the M3 receptors on the endothelial cells and on the smooth muscles, but remember, there's no innervation of these receptors. Under physiological conditions, these receptors are not stimulated because there's no nerve terminals coming down releasing acetylcholine. In addition, acetylcholine is not acting as a hormone, so there's nothing that can stimulate those receptors. Therefore, if just atropine sits there, it's not going to matter. There's no effect. So there's no effect on diastolic pressure. We said for pulse pressure, we're going to only look at the effect of drugs on beta-1 on ventricular myocytes. So this drug is not affecting beta-1 and therefore no effect, and also no effect on mean arterial pressure. Now what's going to happen to heart rate? Here things look a little bit different. On the SA node we have our M2 receptor, but there is innervation. Here we have parasympathetic outflow releasing acetylcholine. And in fact, on the SA node, the parasympathetic outflow is actually the dominant tone. So parasympathetic would mediate bradycardia, and if we block it, we're going to get tachycardia. And in fact, atropine is actually a drug that is used for the treatment of bradycardias. Now, propranolol is a non-selective beta blocker, so it blocks beta-1 and beta-2 receptors. Now, if we first look at our systemic vascular resistance, we could say, well, it blocks beta-2 and there's also some epinephrine floating around, so you could imagine there's an effect, but the classical response, unfortunately, there is no effect on diastolic pressure. Probably this floating around epinephrine is just not enough to see an effect. Now, pulse pressure definitively affect because we have beta-1 receptor on the ventricular myocytes and they are blocked. So therefore you would expect your inotropic state going down and therefore also pulse pressure going down. And in fact, on the ventricular myocytes, the sympathetic outflow is dominant. Sympathetic is a dominant tone. There's not a lot of parasympathetic innervation of the ventricular myocytes. Now, the mean arterial pressure should go down based on those kind of determinants. And in fact, beta blockers are used for the treatment of hypertension, although this long-term effect is more a kidney effect than those things that we just discussed here. Now, in terms of heart rate, again, we have the beta-1 receptor on the SA node. So if we block it, we should get a decrease in heart rate. Now, the next is trimethophan, and this is a NN antagonist. This is a ganglionic blocker. So NN receptors sit in peripheral ganglia. So always when you have sympathetic innervation or parasympathetic innervation, it goes via the NN receptor. So when you use a ganglionic blocker, you basically take away all autonomic tone, all autonomic nervous system. So how do you know a response if you kind of block everything? Well, you have to know about the autonomic tone. So most of our effector organs are innervated by parasympathetic and sympathetic. And as in real life, if two battle for one thing, it's always one is going to be the winner. And when you have dual innervation, the winner is always the parasympathetic. We are rest and digest creatures. But certainly there are circumstances where there's only one innervation, and the first one that we're going to look at here is systemic vascular resistance. What happens to our blood vessels? And you should know that the blood vessels are under pure sympathetic control. So therefore, if you block it, if you block all the tone, you're going to get diastolic pressure decrease. There is no effect on the beta-1 receptors, and therefore the overall mean arterial pressure should go down. And in fact, ganglionic blockers were one of the first drugs used for the treatment of hypertension. Now, what's going to happen to heart rate? Again, we have to consider the SA node. There is sympathetic and parasympathetic innervation, but what is the dominant tone? Well, it's always when you have two battling sympathetic and parasympathetic, the winner is always parasympathetic. So the parasympathetic would mediate bradycardia. If you block it, you're going to get tachycardia. Now, phentolamine is a alpha blocker, and for these tracings, we actually only consider alpha-1 receptors. So alpha-1 receptors, when they are blocked on the systemic vascular, on the vasculature, you're going to get, you block these contractions, you're going to get relaxation, and therefore diastolic pressure is going to go down. And pulse pressure, no change, because we're not going to affect beta-1 receptors, and the mean arterial pressure is going to go down. And alpha blockers were also once used for the treatment of hypertension. Now, what's going to happen to heart rate? Well, there's no direct effects because alpha-1 are not sitting there, but the mean arterial pressure dropped, and therefore there's not going to be a lot of stretch in the baroreceptors in the aortic arch and the carotid sinus. There's going to be less nerve traffic to the NTS, and the NTS is going to do what? It's going to fire sympathetic and withdraw parasympathetic. It's going to fire sympathetic, so we're going to get an increase in heart rate. I also want to mention that trimethophan and phentolamine, when you encounter them on physiological tracing, look exactly the same. So you're not going to be able to differentiate those two unless you look at them in the presence of an agonist. And I just also want to point out that this increase in heart rate has a very different mechanism, because here for trimethophan you kind of block all the autonomic tone, so therefore you're just going to have you're blocking this dominant tone, which is parasympathetic. And here, the increase in heart rate is a response to a reflex because of the drop in blood pressure. This concludes the video on physiological tracings related to antagonists.